Welcome to Rural Health Today. I'm JJ Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. I think an important part, is, I'm going to say it's a sub portion of what you just spoke about. You're talking about you're brought here after that car accident. You're not shopping, but it is important for our listeners to understand that we as hospitals are price takers.
Oh, yeah. Okay? Big time.
Whatever the government sets, I have to accept that, right?
Yeah.
And so understanding in rural America today that for me, 70% of my payer mix is Medicaid, Medicare. Wow. I don't get to negotiate with Medicaid and Medicare. And
what? You're kidding me.
Exactly.
The government doesn't negotiate with you.
There it is, right?
Wow.
And so we're price takers. Mm-hmm. The other issue is that when you look at commercial insurance in rural America, it's really very small as a comparison to government payers because business and industry doesn't exist. Many times hospitals like Hillsdale are the largest or second largest employer in your community. That's not always healthy. But the point is that we're price takers. This idea or concept that's out there that we're these greedy, that we're getting every dollar on that, sheet. That's not the case at all. And unfortunately, though, Elizabeth, we have not told our story. No. I think one of the things MHA has done well at teaching us in the last year is the critical nature and importance of telling our story. And we've done that at Hillsdale. We have a lot of videos out.
Oh, you guys have done a fantastic job.
Our marketing team has done a phenomenal job at getting the voice. Yeah, snaps. An incredible job at getting the voice of the patient who is our pastors, church members, the lady at the grocery store, telling their story. Yeah. I think that is very important because we can get so quickly lost, to your point, of waste, fraud, and abuse.
Yeah.
But when you look at the face of the person at the Dollar General, and you look at the face of your pastor, because I know several that are on Medicaid, that's not waste, fraud, or abuse at all. These are the people and the faces that need it most. So I know we could spend forever on these types of issues.
Yeah.
I do want to tackle two other major issues right now. Number one, there are looming Medicaid cuts coming to hospitals. Now, what I want to do is I want to focus on rural hospitals specifically. So obviously, the Medicaid cuts to hospitals will have a dramatic impact on access for patients. Mm-hmm. It's not just Medicaid patients. When you cut a service, it's cutting that service for commercial insurers as well. And so I guess at the end of the day, give us some good and bad perspectives of what these cuts are going to mean and what can hospitals do to help rebound from this. I think the train's left the station. I don't know how.
I mean, the bill is law. So to some extent, for sure. I mean, that being said, the really beautiful thing about politics is the way that our system in this country and in the state is designed is that you do have the opportunity to fix stuff. You can make changes when you need to. But to your point, some of that is really making sure that you're telling your story, that you're talking to your elected officials, that you're sharing with them the issues that are happening and the things that are going on so that they do have what they need then to be empowered and say to their colleagues, we can't do this. Mm-hmm. These cuts are going to be really serious. What we really want and what I really want all the time is for a legislator to go into a caucus room or go into a committee hearing and say, I talked to my local hospital. And this is going to cost jobs, or it's going to, be really specific. It's going to cost 64 jobs in my community.
Right. And we're going to shut down service X, Y, and Z.
And now people are going to have to drive 2 hours to have a baby. And that means that the few young people that I've got in my community that want to stay here
are not going to stay.
Aren't going to stay. They're going to
they're driving because understand there is no EMS service.
Yeah,
exactly. That's another challenge.
Oh yeah. I mean, I think when you're really looking at like HR1, when you're looking at some of these big looming cuts. Positive outlook, I think there are people still that are fantastic champions for healthcare. Mm-hmm. I mean, we see that at the state level. I think you see it at the federal level. And I think there's glimpses of things occurring where people are demonstrating that they are, in fact, very interested in making sure that healthcare is affordable, but not at the loss of major coverage opportunities or access or at the loss of rural hospitals.
Right.
I mean, that's been a really, really, I think, whether it's at the state level or at the federal level, pretty continuity, like very, very much continuity in the fact that people really recognize that rural healthcare looks different. It's just different.
It's different.
The people that you're serving are experiencing different things. They are coming from communities that have different assets, and they're traveling more.
Yeah.
They have different experiences and they want different things out of their healthcare experience too. And I think there is a really, really deep desire on both sides of the aisle in the politics space and at every level of government to really protect rural healthcare. That being said, people don't always do it perfectly.
Yeah.
They don't, but that's not to say that I think that endeavor isn't real. I do, in fact, think that there are a lot of people in Michigan, especially because Michigan is like the 7th most rural state in the country. So I think people get it that in Michigan in particular, we've got a really unique structure to how our state looks. Yeah, and it is a lot to lose. And I mean, we continue to see those losses mount. And the big benefit, I think, of this time and space is it's an election year.
It is an election year, which is to our advantage, I believe.
Huge.
Wouldn't you agree?
I think it's hugely to our advantage. And I will use my soapbox moment here. Please vote. Tell your listeners, everybody vote. Tuesdays are no longer inconvenient in Michigan. You can vote absentee.
Yeah, you can.
You can do a million different things. It is not inconvenient to go vote, but you have to vote, and you got to vote for folks that are going to care about the issues you care about. And for me, that's healthcare.
Right.
The other thing I would say is if you love this work and you love your community, run for office.
Yeah.
We need people who care about healthcare in the elected positions.
That are passionate about.
Yeah. But I do really think because it's an election year, because people are more engaged than they've ever been before, and because our own folks here in Michigan, our hospital folks, and you included in this, are very focused on building those relationships with legislators, that we do have really strong opportunities for success. I'm not going to sit here and be like, oh my God, woe is us. This is terrible.
We get that enough.
What are we going to do? Like,
I mean, that's every minute of our lives in rural America.
Well, and healthcare is really challenging. You get that in healthcare. I mean, people don't come to the hospital because they're like, you know what, I really feel like lunch.
Absolutely.
Heard they have good pudding. No, people come to the hospital because 9 times out of 10.
Good, but go ahead.
I mean,
it is. It's tapioca.
I'm a blueberry pancake girl.
It's a tapioca.
If you're going to call me to the hospital and I'm going to have
there's
anything,
no pancakes
I'm
here,
going to the
I'm
pancakes.
sorry.
What?
Yeah, no pancakes.
Oh, I can't
We're a
come
healthy
back.
hospital, sorry. But we
blueberries are healthy.
Oh, well, yeah. We'll serve you the blueberries.
Antioxidants.
You
I
can have the
love
blueberries.
All
Okay.
right. You can
Blueberries
make me
it is.
How about a fruit parfait?
No, we won't go that far. But blueberries it is.
Okay,
so blueberries for you.
All right.
Great.
Well, like, people aren't coming to the hospital to have lunch.
They're not.
That's not typical anymore.
It isn't.
I think, if you look historically, hospitals have always been gathering spaces. I think that's very common, and we have an opportunity to get back there, and I think people want that. Yeah. But we've got to protect the asset first.
Right. Agree.
People that come into the hospital are having arguably probably the most challenging day of their life.
Yeah.
So being able, to your point, to tell the story about what rural healthcare needs, what people in the community need to keep having that access point so that they're not traveling far or moving out of the community is really big. And I do think we have those champions. I truly do. And maybe that's, my own optimistic nature, but I'm a firm believer that if you talk to people really honestly about what's going on and you share with them the good and the bad and the truth about it and let them come to the conclusion that makes the most sense for them, they're going to come to the conclusion that local health, local community assets, local employers are the ones you got to rely on when you're making decisions.
Core decisions.
Yeah. Politics is local. Politics is super
absolutely.
local.
Absolutely. I was with Rick Pollack, the American Hospital Association president, a few months ago. Rick shared with us that Washington today is very transactional. He said he's never seen it like this before.
Yeah.
We find that same sentiment reaching different states of their union. And so we find that sometimes it's just frustrating and disheartening for people. But I think it's important to remind our listeners that they have to continue to lift their voice. It's the only way we're going to resolve these issues today. And there's some significant issues that they have to lift their voice. And among those are issues of affordability, access, and another area that we don't think about as consumers, but hospital executives do, that you're an expert at, because I've heard you speak about this, and I'm very excited to jump into this. It's 340B, okay? Now.
We love 340B.
Yeah. Someone listening today who might say, what in the world is that? I thought that was a retirement plan. No, that is not a retirement plan.
It's the tax man coming for you.
Exactly.
Yeah.
I want you to take us through a very quick journey of what it is.
Yeah.
What's at stake today, and what should hospitals, because this is not just a Michigan issue.
Yeah.
This is,
this is probably one of the largest national, highly political issues that nobody knows about.
It is. You're absolutely right.
I mean, it is wild.
Billboards, media advertising,
tons of
that
media.
Is anti-hospital when it comes to pharmaceutical.
Yeah.
So explain to us from the beginning, if you would, very high level, what is 340B? Why does it benefit hospitals? Why do we need it? Yeah. And what is at stake today?
So you're saying not everybody has discussions about 340B?
Probably not. Not even a lot of executives are having that discussion until
Friday
recently.
night pizza at
Probably
my
not
house
340B.
looks different.
Yeah,
than
I would think
everybody
I
else.
think it would, whether it was 340B or not, it would look probably different.
Yeah, that's probably true. I got a buttload of kids, so that
Yes,
happens.
exactly.
Pizza's just a wild experience.
Pizza's just an experience.
Yeah. So 340B is a really great topic area. It's one that I love to talk to people about because it's really fun, and it's one of the few spaces in particular in the state that like you can have an impact as a state legislator on drug prices and affordability and access. But 340B itself can feel really weird and tangential because like, what the heck is it? It's a drug pricing program. So back in the 90s, the Congress was like, wow, we need to take care of some really specific community assets, critical access hospitals, rural referral centers, sole community hospitals, cancer hospitals, children's hospitals, and hospitals that are serving a disproportionately large share of Medicaid patients. So collectively, safety net hospitals. And safety net healthcare providers, so like FQHCs, community health centers, hemophilia clinics, those kinds of things. Things that are like, if that goes away, people are really, really in deep trouble. And the Congress was like, okay, what can we do? What is a revenue stream that we could create? What is something that we can offer? How do we do this? And as we already talked about, like moving things through Congress is really challenging. It takes a really long time. There are a ton of people with a ton of different mindsets representing states from all over the country who have different approaches to how they think things should get done. So they thought really creatively, and they created a program that essentially says, all right, pharmaceutical manufacturers, if you're going to participate in Medicaid and Medicare, that's a benefit for you. You're going to offer these certain safety net providers a pretty deep discount on drugs. Great trade-off for them. They get a massive opportunity to participate in Medicaid and Medicare, and we get the opportunity.
That is their only ability to participate in Medicaid and Medicare.
Exactly. It is conditional. If you do not participate in 340B, you are no longer involved with Medicaid or Medicare.
Right, which is, again, in rural communities, 70% of our population.
Yeah. I mean, and I think really when you're thinking about who are end consumers and drug purchasers, hospitals and the government are two of the biggest ones.
Right there. So
for them, this was a massive opportunity and a massive boon to be able to participate in that program. And for us, it was a really, really special opportunity to be able to deliver affordable drugs, access to care, loss leader programming, and service lines that otherwise you're not going to get to keep. So 340B allows hospitals, certain hospitals, so like Hillsdale, to purchase certain outpatient drugs. So not the drugs that are administered on site, drugs that you would pick up at your local pharmacy. You're able to then purchase those drugs for a pretty good reduced discount. Essentially, what people are familiar with is the rebate side of things, where like hospitals essentially see a rebate, but upfront instead of on the back end, which is great because most, especially rural hospitals and most hospitals globally, are not operating with a ton of cash on hand. There's
you can't
not
wait
some,
weeks, months,
we don't have the
years.
fire drake.
Correct.
We don't have this
the
big pile of
dragon
gold.
Is not
no,
there.
there's no. He's not guarding the gold.
No, he isn't.
So you're not able to purchase these drugs. I mean, when you're looking at it right now, the median cost of a new drug on the market in 2024 is $370,000. It's just the median.
$370,000.
And that's just the median. That's not even the highest cost drug. I mean, the 340B program covers drugs that are cancer drugs, that are $1 million drugs.
Absolutely.
And if you're an individual receiving cancer care in a small community, in a rural community, and you're on Medicaid, or even if you're on commercial insurance, paying for that care is really, really expensive. But 340B means that your hospital was able to purchase that drug at a discount, received the reimbursement for it at the normal rate, and the revenue generated from that space in between, those savings, mean that they can invest in someone's care. And maybe it's not my care. Maybe it's, we'll use hypothetical me. So hypothetical me has fantastic insurance because I work for a fantastic employer. So I don't need the help on it. But hypothetical you doesn't. You have, maybe you have no insurance. You're maybe a younger person and you're like, yeah, I'm mostly healthy. I'm not really worried about this right now.
Sure.
I'm just going to buy, sort of
Which
like
is the mindset today. It is.
I'm not going to buy insurance right now. I'm just going to deal with that later. When I get a job, my employer will cover it and it'll be fine. And then you have a terrible diagnosis. 340B means for a lot of our members that you can go in and get cancer care for $0 copay.
$0 copay.
$0 copay.
That's what's incredible.
Yeah. I mean, for some of our members, it means that they were able to fill over 21,000 prescriptions at a $4 copay for people in the community. If 340B wasn't in existence, we wouldn't be able to do that.
No. Thousands of dollars.
Yeah. I mean, that program generates an opportunity in the community to say, hey, we know what our community members are experiencing, and we can make sure that—
And we want to give care to them.
Yeah, we want to make sure that you have access. I mean, for lots of folks, and I would ask you, like, what does 340B look like for Hillsdale? But for lots of our members, that's the way that we keep OB services in our community.
Absolutely.
That's the way that we have inpatient psych
Correct.
in our community. Like we see people that are in crisis and we want to be able to offer that service. We would not be able to offer it if we didn't have 340B.
Right.
Or discount drug discharge programs are a real common one, which I think is a really cool example of how this program hits individual patients. So like if you, again, I'll use hypothetical me. I've got great insurance, fantastic. I had surgery and my surgery is covered, but I am a busy mom. I've got 4 kids. Mm-hmm. And so the hospital said, hey, I'm going to send you home with your prescription right now. We know you're busy. Yeah. Getting to Meyer can be really challenging. You should just take this right now. I didn't pay for it. I paid a $4 copay because 340B covered that copay. And I was like, sweet, that is money for diapers.
Yeah, it is.
Heck yes.
Yep.
And I go home and my outcome is fantastic because I had easy medication adherence. I didn't show up at my local pharmacy and find out that my copay for that drug was
X amount of
$300, $500.
And I have to pay rent tomorrow.
Yeah, or even $50. I mean,
$50.
I didn't find out that it was something I couldn't cost. So then I went, okay, I'm going to put this off.
Yes.
And then I get home and I get an infection.
Right.
And then instead of having this $50 cost, I'm readmitted to the hospital because I have something terrible happen.
200% more costs than that.
Yeah, exactly.
Yeah.
And then I'm really struggling.
Yeah.
340B prevents those types of things from happening because people can
But
go
Elizabeth,
home.
the pharmaceutical did not get their $300.
I'm so sad for them. They're doing so poorly.
Yeah,
have you seen how much money they make?
So that is the point. I think we have to be real in our discussions, don't you? That they're not mealy mouth, poor folks running around.
No, I mean, and this is a big substantive difference. I mean, this
is a huge...
Like, the hospitals that participate in 340B are nonprofit, mission-based organizations.
Right. The largest employers in their communities, providing care to the communities that disproportionate share volumes of Medicaid patients who are keeping their doors just barely open with no margin.
Oh, yeah. I mean, I think
that's what we're talking about.
The best margins we see in healthcare right now are like 2 to 3%.
Well, introduce me to those folks because I'd like to learn what they're doing.
I mean, that's like, nationally. And I mean, just a couple of years ago, Michigan was one of the few states that had hospitals with negative margins overall.
Yes.
I mean, we are not, again, because we have an aging population, we have a lot of folks who are really complex to care for. It's really expensive to provide that care. And then on top of it, though, we're maintaining this like really cool thing in Michigan where we're still third from the bottom when it comes to overall costs.
Yeah.
So like we're like 189% of Medicare in Michigan when the national average is 244%.
Right.
Like we're doing a really good job.
Doing a good job.
But 340B is how we keep doing that good job.
But it's on the chopping block right now in many cases.
It's on the chopping block in a lot of
right
places.
now, you've got states that are looking into it.
Yeah.
The federal government is
having... the courts now.
And the courts now are weighing in.
Oh,
so you got 3 rungs. Everybody's looking at 340B. And you hear a variety of conversations happening at the state houses. You hear it at the federal government level and now the courts about what is the impact of 340B. Yeah. All right, so at the heart of the matter today, what is being debated in terms of how this program should look? Yeah. Look at it from the lens of the pharmaceuticals pushing one thing. They want rebate models that it pays afterwards and all of those
because they've been
challenges.
such a great partner.
Right. They're just going to be naturally honest. Come on, man.
They're as direct and honest as I am.
Yes.
So they're going to be a great partner on this, and I am not worried at all, which is why we oppose that rebate model.
Exactly.
No, it's a ludicrous model.
It's a ludicrous model.
Well, it's when you're looking again at pharmaceutical manufacturers who have 20, 30% operating margins, trying to make this nexus between themselves and a nonprofit, 0% margin hospital, largely in Michigan, again, a local community, small independent hospital.
Right.
Who do you think the argument, who the argument that you should believe?
Yeah.
To me, it should be really easy. Like, it should be really easy. Like, oh, well, these guys just have a marketing team that's like doing something and this is whatever. But for whatever reason, because of their ability to translate this, it's made it a very challenging environment to try and talk to people about the impact of 340B, which again is funny because it's coming from folks who on shareholder calls are like, well, we did really great this quarter because we were able to reduce 340B even further. And so our margins are up even more. Mm-hmm. I mean, that's the mindset that when you're looking at pharmaceutical manufacturers and adversaries in this space, the mindset is if we can make 340B go away, we're going to make more money. So that's what we should do. Mm-hmm. From our perspective, if 340B goes away, we're in a big set of problems. I mean, for a lot of hospitals, and especially rural hospitals, it is the difference between open and close. Like we had a hospital in the UP close not too long ago. And a huge reason for that was they lost their 340B status. They wanted to move over to being just sort of like a very specific type of rural hospital. But in order to do that, they had to let go of 340B because that type of hospital is not yet qualified. A rural emergency hospital is not yet qualified as a 340B covered entity. Certainly we're advocating at the federal level to make sure that rural emergency hospitals are recognized. Because if you're converting to a rural emergency hospital, you're already in a space where you're financially vulnerable, your community is very vulnerable, your patients are very vulnerable. Why would we not do everything in our power to make sure that you could have every asset at your fingertips to serve your community?
Right.
And to provide them affordable access and high quality access. So we're advocating for things like that. We're advocating for legislation that would just ban the rebate model full out. We're working on spaces there.
But Elizabeth, what happens if the courts get involved at the federal level?
Oh, and
This could foil all of the respective states, right? I mean, once a federal order comes out.
Well, that's one of the wildest things that we're watching right now. There's definitely an endeavor, and manufacturers are very well funded.
Yeah.
And they've got a lot of very well funded legal teams that go out and sue in every state that's got contract pharmacy laws.
They do.
We've got a lawsuit from one of the manufacturers on the definition of patient and whether that's too broad. We've now got the federal government engaging in some of these lawsuits and submitting amicus briefs saying, well, we think the federal law preempts these state laws. This is a 180 shift from, a couple years ago where the federal government was like, no, we don't. That's absolutely a states' rights thing.
Yeah.
States have the right to regulate the health and welfare of their residents. This is absolutely within the purview of the states. This is not within the purview of the federal law. Like, we say that you can contract with a pharmacy. We don't say anything about how many.
No.
So if a state wants to say you can contract unlimited, then that is the state's purview. That's what we're going to continue to push at the state level.
Right.
We're monitoring those legal issues really
do you
closely.
Do you think looking at the federal court intervention, do you think there's any potential risk there soon?
Yeah. Soon is a really loose term in the legal world. Much like the Congress, the courts are not particularly snappy. They move at a pace that they feel is comfortable for them.
But there is a risk that they will pick it up.
Yeah, there's a huge risk. And we're seeing this sort of snowball effect occur where there's a couple, district court opinions and appeals court opinions that are sort of starting to get into this space a little bit more and more and more. I think probably if I am putting my lawyer hat on, the endeavor is to try to create a split circuit setup where you've got two federal circuits that have made two different decisions, which then gives you the opportunity to take it to the Supreme Court and say, Supreme Court, it's your turn to weigh in. Our circuits are not agreeing in this space. We've got, one set of folks who think that the states can do this, and we've got one set of folks who thinks that the federal law preempts it, which is why you're seeing this. That's why you're seeing these legal arguments come to fruition. Because if those two different sets of opinions exist and they can't align, then the Supreme Court has to come in and basically be like, okay, this is what we actually decide. And that'll be really wild if that happens.
But so where does the public come in on this? Where does the consumer, encouraging their state representative and state senator that these are important programs?
Yeah, start there. The other thing too, start by spending just a little bit of time when you see those ads, when you see things come up. View them with a grain of salt. If somebody's being really aggressive in an attack,
there's got to be a reason.
There might be something behind it, and maybe that's the lawyer in me again being like, I'm curious.
No, I think that
but be curious about
it. A
it.
layperson would figure that out.
Yeah.
I received a call from one of our state legislators that said, true story, he's pro-life. And the 340B used a third party basically to send him a message that the 340B pricing drug program is supporting abortions at hospitals. True story. And that had been the first time I had heard of that type of rhetoric. But they are using whatever means necessary to target individual legislators and their political positions, their personal convictions.
Oh, absolutely.
As a way, and I'm like, that is not true.
No.
It's not happening. There's very few hospitals that I know of in Michigan that even do elective abortions.
No.
But at the end of the day, to tie that in, this shows how desperate they are.
Oh, yeah.
And the shift has come from how greedy and, tens of billions of dollars that they're making in this industry and, tens of millions of dollars our executives are making, to the bad guys are hospitals. And that's really what's sad is their ability to do that. But I think to your point, voice of the patient, talk to your legislator, tell them, I benefited from that $4 script.
Yeah.
Because that's how that works. If that goes away.
Yeah, the $0 copay is how I got care.
That's done.
Or I am a young person and I love living in my community. And if they don't have OB anymore, I'm going to have to drive 2 hours now. And that's time that I have to take off work.
It's life or death if you have an abruption.
Yeah.
It's life or death.
Well, and even just from a, like a personal story convenience space, okay, so now I have to spend.
Where am I getting my care?
Yeah, I'm spending 4 hours
Prenatal
back and
visits,
forth.
the whole 9 yards.
Well, and okay, so do I have to take PTO for that?
Right.
Am I going to be able to schedule it in a time where I can get the time off? Do I have a reliable vehicle?
Right.
Do I have the money for the gas?
Absolutely.
I mean, there's an incredible array of other things that go into those decisions.
Right.
And keeping that service local, means that you're serving your community. It means that you're meeting what your community wants to see. But from a rural health perspective, too, I mean, you're also really looking at keeping high quality access and outcomes that are really positive for your community members. Because you're right. Like, when I'm thinking about this, I'm thinking about the people that sit next to me at church or the people that I see at the grocery store.
Yeah.
I don't want something bad to happen to any of those people. They're people that I like.
Absolutely. Family.
I don't want bad things to happen to my coworkers. I want them to easily be able to go, within 15, 20 minutes to their local provider, to their local hospital, and get the care that they need.
Yeah.
Not be in the car for 2 hours, not have an abruption in their car.
Absolutely.
Not, be in a space where they weren't prepared and the hospital wasn't there anymore.
Yeah.
But to tie it back, I mean, 340B is a huge reason why those things continue to
exist. It's a huge reason why we have those programs as community benefit.
I mean,
we're not going to prop up a program like that without the sport.
No, I mean,
doesn't exist.
None of my children were born at a pharmaceutical manufacturer.
Absolutely.
They were all born at a hospital.
I bet you they're quite like pills, but still, I mean, they're the pill. Boom, boom, boom. All right.
That was
did you like that?
Wow,
they're the
that
pill.
was a peak dad joke.
That was
really
Thank
good.
you so much. I appreciate that.
Congratulations.
Our producer, Kirsten, will probably be rolling her eyes in the studio about that. But anyway, so listen, I could talk to you for hours about these issues. It's very clear about your passion. I want to thank you. As a rural hospital, the work that you do in Lansing, and then some of your team members in D.C. I think your focus is a lot in Lansing,
Very
right?
much in Lansing, yes.
But, you, Adam, Laura, and the team do such a great job at advocating for hospitals. And the beauty of it is it's not just a big system or when we go to the table, it's everybody.
Yeah.
And so when you lift your voice for one, you're lifting it for all of us. And I just want to thank you for that. The work that you do is truly incredible. And we could talk for a very long time about the progress that's happened in advancement that MHA has made for hospitals like Hillsdale and others around the state in areas of nurse staffing ratios and disproportionate share and average commercial rate, and the list goes on and on. Interstate compact.
Yeah.
The work that you're doing is incredible. I'd encourage those who are listening in states where Michigan has 100% participation from all hospitals, so that's great. Not all states do. We've interviewed just about every state Office of Rural Health, and we're hearing stories about there's not always that cohesiveness in each of the states, respectively. And Michigan is one that has 100% participation. I would say to our listeners today, if you do not participate or belong to your rural health association, get involved.
Oh, yeah.
You cannot lift your voice independently or in silos. It has to be done in consort with people like Elizabeth Kutter, who are out every day knocking on doors, directly impacting the lives of Hillsdale residents. Thank you for what you do.
Oh, my goodness. Well, you make it very easy, and it's very fun to get to advocate on behalf of our members, because it is truly one of those things where when you're passionate about an issue, when you're passionate about the things that are occurring around you, when you've got members who share that passion too, it just makes it more amplified.
It does.
It's more fun.
It does.
I love to do an advocacy day and have our members come to Lansing because they get to see what I see.
Yeah.
Legislators, as much as the environment itself, very challenging. The political environment is super challenging. If you're watching TV and you're taking in the news, it feels
you turn it off anymore.
Yeah, and it feels heavy.
It's heavy.
But when you come to an advocacy day and you get to talk to somebody, you're like, oh my God, these are just regular people.
This is different.
They're just regular people.
It's not what the media portrays.
Exactly. But that's, I mean, I thank all of you guys, because I couldn't do this without our membership.
Yeah.
I can't talk about our programs unless you tell me what it is that matters to you.
Right.
And I can't talk about the patients impacted unless I know them.
Yeah.
But those are the things that matter the most. And my only parting wish for all community members in every space is just get to know your local elected officials. Get to know them at the
advocate.
Get to know your mayor, your county commissioners, your township supervisors, everybody.
Yeah.
because those folks are going to be people who
they're
are
decision
making
makers.
Yeah, they're making decisions that impact all of us.
They do.
And then run for office.
Yeah.
Run for office because we need more folks who care so deeply about rural healthcare.
Yeah.
And we need people with healthcare experience.
Right.
I mean, if you're a provider, please run for office.
Yeah, absolutely.
We need providers in office.
The burden, the task, the duties, but I think it's just been the environment lately of the negative that keeps some folks out. But there's a way to change that.
Yeah.
You get involved and you redirect the conversations.
Exactly.
We're seeing that happen here locally as well, where they're redirecting conversations because it's just becoming very, very nasty. So anyway, it's been great to have you on the podcast.
Oh my God, thanks so much for having me.
I've got one more thing for you. You've been to a lot of places. You've worked at a lot of places. Is it just you can't handle a job, or is it, what is it? I mean, 10 jobs in the last 10 years. But that means you have experience. And so what I want to ask you is, we have leaders from across the country that listen to this podcast. And I want you to give them a piece of advice. Someone new, a leader maybe that's stepping up to, in today's environment of healthcare, the most tumultuous of times.
Yeah.
I mean, who wants to get involved today? There's an exit, and there's a huge exit, though, of leaders in healthcare. They're just, we're done.
Yeah.
What advice would you give a young, maybe they're in the role right now or getting ready to assume the role, of what they can do to be successful? What tips, advice, sage advice would you give someone that's struggling right now, or that may just be, I want to do this differently?
You asking for my sage advice because you think I look old?
I should. What's better than sage? Your Mercury
first
advice?
You told me that I
can't keep a job.
And then you accuse me of being old. No, I'm kidding.
No.
So I think those are all really good
Your
questions.
kids are pills, so that's all great.
That's
great.
They're really precious ones.
They're prizes.
Oh, what a treat and a half. So in terms of advice, I mean, I think, again, like, it's really very much found in that, like, stay curious space. Get involved with your association. Get involved with other local entities too. So, like, get involved with your local chamber. Get involved with the business community.
Yeah.
Get together with
Those
local
are the faces.
leaders. Yeah. Get together with folks in your community and get to know them, and know them authentically. You made a point earlier that, people feel like politics, especially at the federal level, is super transactional. That can be applied anywhere. Don't let it. Make authentic relationships. Be an authentic human.
Yeah.
Because that's how we're going to actually change this rhetoric. It's how we're going to change the tides around what's happening in the political sphere. And it's how we're going to make sure that we can preserve what matters the most to folks. And, and what those community assets really look like is being curious, being authentic, being willing to put yourself out there. The advice I always give, especially to folks who are coming up in the political realm, is just be willing to make the cold call. Get a coffee. People and legislators are the same way. And I think people globally are like this. It's really easy to not do it. And I think one of the negative products of the pandemic was we got really comfortable just being like, well, I don't have to do that. I can do it via Zoom, or I can text somebody. I don't really need to do
laid
that.
Back,
and
time.
That's fine. And there's a time and place for all those things. But in this world right now, and in this politics space especially, be willing to reach out. Reach out to somebody, grab a coffee, tell them about yourself. Yeah. Just have it doesn't have to be an ask. I think that's a common misconception. So the advice that I would say is you don't have to have an ask if you're meeting with a legislator.
Sometimes they don't. It's nice for them not to get that.
Exactly. Just go in and introduce yourself and say, hey, I
just want to learn a little bit more about you.
Yeah, I'm
or
Elizabeth.
The process.
I'm with the Hospital Association. I like sourdough and girly pop music. Just talk to them about those kinds of things. And you're going to find places where you have a lot of relatability, a lot of overlap, and then you have the ability to negotiate a much better solution with somebody who sees you as a person and not a transaction. Yeah. I'm not some, paid hit or like whatever, lobbyists get a bad rap as being part of the swamp or whatever. They do. I'm not Shrek. I don't live in the swamp. Yeah. Like, I'm a regular
But at the national
person.
level, that's what has been told to our, electorate, is that lobbyists are bad, evil, you're part of the problem.
66%
evil. But at the end of the day, without you lifting your voice, I shudder to think where Michigan hospitals would be.
Thank you. What a compliment.
I really do.
But yeah, that would be my advice.
Yeah, great advice.
My advice to folks would be curious, develop those authentic relationships, be willing to just make the cold call.
Right.
You don't know someone until you meet them, so you might as well meet them.
That's right. And sourdough and girly pop, what was that called?
I love girly pop.
Girly
so like
pop.
any type of pop music. Oh, like I love a Taylor Swift.
Okay.
big fan of like anything that's going to be.
Twain, like
I love
that.
Shania Twain.
Okay.
Let's go, girls.
Okay.
Absolutely.
So you got it right.
I'll get any of that.
Raisin bread and gospel for me.
Ooh, you love raisin bread?
Yeah,
Like
absolutely.
a cinnamon swirl or just
with
like
the icing on the top.
Ooh,
Yeah.
so I
Crispy.
love to bake. I'm a big baker. That's
Okay.
I love that. That's
Nice.
always very fun.
Nice.
I love, like I said, I love silly pop music.
Well, good for you.
And I love to read.
So then
Big reader.
everybody should know that about you. So share your story. And
Oh, don't worry.
Everybody
They know.
does.
Everybody knows.
There is a part of me that knows that to be the truth.
If you were to poll any of my friends and you were like, hey, what is something that Elizabeth loves?
Yeah.
At least 5 of them would be like, she loves the fictional pop star Power line from a Goofy movie.
Nice.
And Eye to Eye is her favorite song.
Okay.
And I would be like, yeah, that's actually
So
very
probably
accurate.
75% of this podcast is going to be edited because it's been fun.
Yeah.
This has truly been fun.
Oh, you don't like fictional pop stars?
No, not at all. But still, it's all good.
Boo-hoo.
You know, it's a tough life. It really is.
Yucking my yum.
Yeah, I'm sorry. It is
Okey-dokey.
what it is. But Elizabeth, it is always a pleasure
Thank you.
to have you present. And
course.
first time at the studio today. Hope to have you back.
Yeah.
Because I want to post budget passage to talk about what the implications are going to be for hospitals.
Yeah.
So maybe we could do that.
I think that would be great. I mean,
Right.
I think from a hospital perspective, our biggest fight in that space is making sure that Medicaid is fully funded.
It is.
That's what we're going to endeavor to do.
That's the starting point, right?
Yeah, I mean, I think we're in a good spot to
Yep.
get that done, but we're not going to stop until it's fully done.
I agree. Great job.
Thanks.
So thank you, Elizabeth, for your time today here on Rural Health Today. And thanks to our listeners for tuning in. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health care every Monday, wherever you get your podcasts. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed so you never miss an episode. Until next time, remember, rural health strong.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.